I'd like to thank Dr. Matthew and the organisers for the opportunity to be here, and I'll discuss imaging guidance in bifurcation PCI. These are my disclosures. So why imaging in bifurcations? I think we've partly answered it already, and many of the issues have been addressed. And this was a long segment calcified LAD. This was actually a aluminum 4 roll-in patient treated with a provisional strategy, but we needed to cross over, bail out the side branch, and I'll come to why. But we got a really good result angiographically through the LAD long segment and with the diagonal restored patency. But what you see angiographically with complex intervention is not necessarily what we always get, because we can see at the diagonal by OCT, ostium, despite a tap, a kiss and a repot, we've got a train wreck with a completely crushed stent despite a nice angiographic result with tissue, some thrombus. This will predicate stent failure, and if it's restenosis, we're lucky, it'll probably be stent thrombosis. So why imaging guidance? I think very valuable in high-risk lesions, subsets such as bifurcations, higher TLR, stent thrombosis. We have high level of angiographic ambiguity angiographically with overlap, foreshortening, and OCT precision, particularly with co-registration, although we can get it with some of the IVUS systems, but OCT allows, as you've seen, 3D reconstruction, assessing the side branch with a main vessel pullback. We've seen a number of issues in the last few cases really showing the benefits of this approach. Imaging identifies correctable factors, really important in complex intervention. But it's data-driven. There's a wealth of data with imaging in intervention, and this is data from the BSIS, the British Cardiac Society, looking at 12-month mortality in unprotected left main intervention, angio-guided versus IVUS-guided, showing absolute 4% risk reduction of death with imaging guidance, and the benefits with IVUS was compounded by high volume. It was impacted positively the more volume, the higher volume the operators are. So obviously using imaging, but using imaging optimally. So as we move forward with OCT and trying to integrate the data, as I spoke to fully inform the procedure with all the inputs, the algorithm, MLD max, I think that's just as relevant for bifurcation PCI. But particularly OCT in bifurcations pre-stenting to characterise the plaque and the complexity of the plaque in the main vessel and side branch, speaks to modification, but it also talks to strategy. We may switch from a provisional to a 2-stent strategy or vice versa. It allows us to size our stents and our balloons, and remember with a provisional we size our stent to the main vessel distal to the side branch because of fractional geometry. The bigger the side branch, the bigger the step, and we've spoken about predictors of side branch occlusion, and extreme carina shifting is a very important factor. If we oversize the main vessel stent to the main vessel proximally, we have extreme carina shifting. It tells us what pot balloon to use, and we can establish an appropriate length from the carina to our planned proximal stent margin to be able to pot optimally. And this is what we've spoken about with the last case with the elegant data from OCT from Japan with a spiky carina tip, narrow carina tip angle, short branch point to carina tip, and eccentric plaque on the contralateral wall. So we come back to our patient. We showed this on a run through the main vessel that we had grade 4 calcification. So this, we know, will not respond to conventional balloon dilatation. It'll predicate stent malexpansion, which is an important predictor of stent failure. We also showed we had a narrow carina tip, we had a short branch point to carina tip. So again, speaking to risk of side branch occlusion. And that's exactly what we got with this case. That's why we had to cross over. I dismissed all our signals. And importantly, with that calcified plaque on the contralateral wall, we really, with suboptimal preparation, and that's what I had with this case, balloons bulge into the side branch, we get a less efficient plaque preparation. We really need to optimally use atherectomy here, I think. But in bulging into the side branch, we dissected the side branch. There was no manipulation on that side branch, and it occluded through this mechanism. Use the data, incorporate the data and optimize the results. So during stenting, we can continue to monitor the side branch. Importantly, we can locate our recross point in important bifurcations, and we can ascertain the extent of strut clearance. And that's where the online 3D bifurcation software is really, really helpful, facilitating the understanding complex anatomy and the device strut-wire interaction. But despite the compelling bench data, where we must always kiss with a bifurcation, that's what John Ormondson would tell us, that's not what the clinical data shows. Clinical data with routine kissing in a provisional strategy can show benefit, but there's heterogeneity. Other studies show neutrality, and other studies with routine kissing show harm. And when there's harm, the penalty is in the main vessel, because as you were shown with that lovely bench model, you pull the stent off the contralateral wall with a suboptimal kiss. So kissing, based on the angiogram in the real world, clinically angio-driven, can be harmful. As I said, we can have that adverse stent deformation, not the positive deformation that we want, as we see on the bench. We can get the malapposition, the suboptimal kiss. We can get an asymptomatic ovoid expansion in the proximal vessel. We can go abluminal, and we don't know because it's not evident angiographically. And of course, we can dissect the side branch. So this is the disconnect between the angio approach and the bench, and it predicates the potential and the value add of imaging in an important bifurcation where we're considering a routine kissing strategy, such as a left main. Because if we recross proximally, as opposed to distally, in a provisional strategy, we can create this neo-carina. We're not only not scaffolding the ostium of the side branch, which is the ideal with a provisional and a kiss, we're actually pushing struts up into the lumen towards the side branch, towards the main vessel. And that is intrinsically not a good thing. It's shown on computational flow to perturbate adversely endothelial shear stress. It's associated with turbulence, activation of platelets, and potential for complications. So if we on the left panel, you can see the cross-section and the 3D recon following a rewire pot and then a rewire, and this is before a kiss. We can see a lot of stent struts at the mouth of the side branch on the reconstruction, and on the right is following a kiss, and we can see the clearance that we're trying to attain. But importantly, on the left, we're able to confirm we're in a distal cell and we're not proximal. Additionally, the imaging in important bifurcations with a provisional is to make sure we're not abluminal. And this is an example of a collot where we've gone on the angio panel at the top, stent from LAD into a large diagonal. Presumably a pot was done, but after the rewire into the LAD, you can actually see the OCT catheter is not within the stent. So this stent is A, underexpanded, and B, is not optimised with a pot. If we proceeded angiographically, we would balloon, we would then stent into the LAD, and we would have multi-layer across the mouth of that side branch, make it incredibly difficult to rewire. So it's a train wreck waiting to happen. It's very important to image in these sort of complex bifurcations. That's the kind of message. I'm not talking about a 2-0 posterolateral. So how to incorporate this imaging into a provisional strategy? Well, I think you just need one more OCT. Obviously, we plan the procedure, wire in LAD diagonal, but we're doing the OCT run in the parent vessel. We do get a sense of the os of the side branch, but we're planning our main vessel intervention. We pre-dilate, I prepare, stent the main vessel, jailing the side branch wire, sizing the stent to the main vessel distal, oppose the stent proximally with a pot from the carina, and opposing the stent proximally, rewire the side branch, then do your extra OCT run to check your pot result, your apposition. Importantly, check that you're not in an extremely proximal cell and hopefully a more distal cell with a significant bifurcation. Then we can kiss, and then we can repot, and then the final run. So I don't think it adds a lot more to the procedure. Once again, this is, I think, significant in a provisional left main, important context. So again, OCT, post-stenting, it's all about ensuring apposition, but particularly expansion, ensuring we don't have edge pathology, landing into significant plaque burden, dissections. We have the ability to use that 3D reconstruction and confirm that we've got struts clearance from the mouth of the side branch. But certainly this is an example using co-registration, but this is with Ivis. This is a 71-year-old man who, whilst awaiting a nephrectomy for apparently curative right renal malignancy, presented with unstable angina. He was troponin negative, normal left ventricular function. He had a bulky plaque angiographically in his mid-LAD adjacent to quite a substantial diagonal side branch. So this is a man who's about to have a nephrectomy. He, by definition, is high bleeding risk because his DAPT is going to be compromised in the short term. I think an important indication for imaging alone, let alone to be a bifurcation. So we planned the procedure using our SyncVision software, analogous to the OCTs that you've seen. We can assess the lesion, which is very fibrotic, lipidic, negligible calcium, plan our procedure, get a distal reference, get a proximal reference. We can do a virtual PCI with length, so 16 millimetres. We were using an 18 millimetre stent here, 4.9 proximal, 3.7 distal, 3.58 conservative stent, pot with a 4.5, distal optimisation with a 3.5. So we kissed, we repotted. We had quite a good angiographic result, a bit of minor pinching of the side branch, but normal flow, no ischemic pain, and no ST segment deviation. Re-interrogated, and to keep it simple and brief, we had gross malapposition, malexpansion at and distal to the side branch, and proximally, very proximally, a malexpanded stent. And again, our measurements were 3.7 distally, almost 5 proximally, so we re-optimised with a 4.0, 3.0 KISS and a repot with a 5. And final angiographic result, again, we're happy with the angio. Well, in this occasion, we've got apposition and we've got expansion. Very important, it's a bifurcation, but more importantly, this man's about to have his clopidogrel cease so he can have his kidney removed. This is a very important and very considered opinion piece, synthesising DAPT duration after bifurcation PCI. It's worth a look in your intervention, strategising based on stability versus ACS, a 1 stent, a 2 stent of bailout, but particularly whether it's a high bleeding risk patient and whether imaging was utilised. So this is not evidence-based, but I think it speaks to the importance of imaging. Particularly, we need an opposed and expanded stent when we're going to compromise DAPT in the short term. So to finish with, what are the goals in bifurcation PCI? Well, we know, and we've seen the data from Kang with in an Asian smaller population in South Korea, the rule of 5, 6, 7, 8 millimetres squared with a complex bifurcation intervention. Some retrospective data from Excel in a Caucasian population, bigger, 6, 7, 10 millimetres in the proximal main stem. This is a guide, and this is the sort of numbers with the minimum numbers we've generally based our left main complex intervention on. More recently from Spain, De La Torre Hernandez has proposed predefined optimisation criteria in IVIS-guided left main stem PCI, provisional versus 2 stents. Certainly in the left main provisional, MSA, more than 90% of the proximal left main reference, unless we've got a tapered left main, ensuring we don't have stent deformation, longitudinal stent deformation with a guide or recross. And adequate stent edge in the LAD distally and expansion of the LAD. To a 2-stent strategy, again, more than 90% in the left main, more than 90% compared to the reference in the prox LAD, and more than 90% in the proximal circ. We want to exclude proximal stent deformation, again, in the left main, and on the stent edges and the limbs, less than 40% plaque burden where we land our stent, and absence of dissections. So this is not just using IVIS and partially incorporating, this is a predefined set of criteria. And if we apply that with the IVUS Pro prospective versus historic IVUS data, we get based on this retrospective, it's not a prospective study, that's happening with the Optimal study, we have better left main stent areas, we have better stent areas in the limbs, the LAD and the circumflex artery, we meet the expansion criteria in 88%, we have complete apposition in up 95%, and we're really significantly reducing the likelihood of landing in significant plaque. And again, smaller numbers in terms of clinical endpoints. We have lower event numbers in terms of left main, target LR, target lesion revascularization. The primary endpoint, the composite, compared to angio, the IVUS Pro approach with predefined strategies has a significant advantage in terms of the composite endpoint. But we really look forward to utilising this in a randomised context with the Optimal study from Europe. So we do look forward to the October study, and we've heard about that. That's a randomised study in a bigger number of patients, 1,200, bifurcation, PCI, including complex interventions, angio versus OCT guidance, and the concept study, Optimum, smaller study with OFDI, really looking at the ability to the 3D mandated OCT guided PCI versus angio. So in conclusion, I think imaging guidance in bifurcations is a particular value without the limitations of conventional angio. We can permit a tailored stepwise approach. We can incorporate the MLD max algorithm, but bifurcation specific, evaluate the disease extension, plaque morphology. We plan, we can guide our modification, choose our devices, optimize. Importantly, guidance to the rewiring the distal cell is very important with the provisional strategy, and hence the added value of the 3D recon. It excludes that we're accidentally abluminal. And finally, IVUS guidance of left main stem intervention. There is prognostic evidence over angio alone. It's particularly important using a protocol with predefined optimization criteria, as I showed towards the end with the Spanish data. So I'll stop there, and I'll finish with the concept. Bifurcation is a metaphor for life. You've got to make a decision. You've got to take your choices, and that's exactly what we do with complex intervention. So thank you for your attention.